Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode, I'm joined by Aaron Goodman. Aaron Goodman is an assistant professor at the University of California, San Diego, and he's here to talk about hematologic malignancies and transplantation, his specialty. You won't want to miss this discussion. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD, MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. I'm back in Plenary Session, joined via Zoom by Dr. Aaron Goodman. Aaron Goodman is an assistant professor at the University of California, San Diego. He's a practicing bone marrow transplant doctor and expert in hematologic malignancies. Aaron, it's a pleasure to have you on the podcast.
Thanks. I've been listening for a long time, and it's a pleasure to be on your podcast.
We have teamed up on some stuff recently. We took a close look at this interest in treating multiple myeloma early. As you know, if treating a cancer is good, treating a pre-cancer that often doesn't progress to the cancer is even better. Got to be even better. Why don't you tell us a little bit about this idea of treating smoldering multiple myeloma? What are your thoughts on this topic?
Yeah, so for those who aren't super up-to-date on the smoldering myeloma field, so all patients with multiple myeloma progress from an asymptomatic MGUS stage where they just detect, usually incidentally, a monoclonal protein in the blood. And their risk of progression to overt symptomatic myeloma is about 1% per year. A subset of those will go through this intermediate phase that we call smoldering myeloma, which the definitions have somewhat changed over the course, or specifically the risk of smoldering myeloma. But basically, the definition right now stands as you have to have 10% more plasma cells that are clonal in your bone marrow and or 3 grams per deciliter of a monoclonal protein. And then this is further divided by various groups, the Spanish, the Mayo group, into low or high risk. I will just focus on what seems to have been adopted in the United States, which is the Mayo risk model, which is the 20-20 model, which is 20% or more plasma cells in the bone marrow, an M spike of 2 grams per deciliter or more, or a kappa to lambda or lambda to kappa ratio of 20 or more. And with that, you can divide smoldering myeloma to 3 different groups. And the more of those risk factors you have, the higher percentage will progress to myeloma. And I just want to redefine myeloma. To me at least means symptomatic disease, end organ dysfunction from the disease, renal failure, lytic bone lesions, anemia, distress related to the cancer.
Yes.
We now have a new classification as of 5 or 6 years ago where you can technically be asymptomatic, which to me still is the smoldering stage, but we now call these patients true myeloma. If you have 60% or more clonal plasma cells in the bone marrow, or a kappa to lambda or lambda to kappa greater than 100 to 1. Okay, and that is another controversial issue that we can talk about more.
Yes, okay, so this is great. So now I see in my mind the bins. We've got multiple myeloma, old school multiple myeloma, where you had to have end organ damage. And that's the myeloma that we grew up with learning in medical school. Then we got new myeloma, which is the expansion to include the skewed free light chain ratio of 100 to 1, those plasma cells, and MRI findings. And now that's called myeloma, even though that wasn't the old myeloma. It used to be smoldering, and to some degree it kind of still is. And then there's smoldering, and then there's the high-risk category of smoldering. And then a few years ago, those folks in Spain did a very small phase 2 randomized control trial looking at lenalidomide dexamethasone versus observation in high-risk smoldering myeloma by the Spanish criteria. And they found not only a PFS benefit, which is what it was powered for, but an OS benefit. But because the trial was a small, underpowered study, and because the control arm, when they progressed, they didn't get VRD. They got carfilzomib regimens and regimens that, our grandpappy used to give. They got old school regimens. And so that trial doesn't really tell us if treating smoldering myeloma early is better, because you have to compare treating early with novel drugs to treating myeloma with novel drugs when the control arm progresses. So I think that's kind of a not very useful study. And then we had the ECOG study, which was supposed to be the answer. The cooperative group study, lenalidomide versus observation in high-risk smoldering myeloma with a slightly different inclusion criteria, different high risk. And this had a PFS benefit, which was kind of obvious. It didn't surprise me there that active drugs given early will have a PFS benefit. But it didn't have an OS benefit because they crossed everyone over without waiting for the OS benefit, without waiting to see. And so that's not going to be very informative either. And I think on this podcast, I faulted the trialists for doing that. So we have this interesting situation where, 20 years ago, we wouldn't have treated these people with myeloma who didn't have end organ damage. We wouldn't have treated smoldering myeloma because we didn't have trials showing that there's a survival benefit from treating early. But now we do treat it, not all of us, but some of us, and they still don't have that data. They still don't know. So that makes it tough as a doctor. I mean, how do you counsel a patient in this situation who's probably feeling fine? I mean, by definition, they are. How do you counsel them about this decision of should they start treatment early or not with, high-risk smoldering myeloma?
Well, let's take, the most recent recommendations, which is to strongly consider Revlimid for high-risk smoldering multiple myeloma. And again, high risk by that Mayo criteria, the 20-20. Yes. And you're right, that study did show a progression-free survival advantage, which is no surprise. We gave active therapy. We prolonged the time till symptoms. But my interpretation of that study is the second those asymptomatic patients, the second that Revlimid touched their lips and they swallowed it, they progressed, right? I mean, they got treatment.
That's right, yeah.
That's how I look at it. So to me, it's a win for the people who did not take the Revlimid. I mean, think about what we're doing in smoldering myeloma. We're giving chemotherapy to delay the need for chemotherapy. That makes no sense.
It makes no sense.
It makes no sense. And I think we all know that single-agent Revlimid is not going to cure smoldering myeloma. I think we can say that with fair confidence. And this trial will not answer that question. It will never answer, unfortunately, as you pointed out on your wonderful podcast, any meaningful question. It was destined to do so, but unfortunately, it is not. And I think and we can talk more about it and expand upon this. Now that the myeloma community is kind of accepted Revlimid now as the control, what we need to be doing for our smoldering myeloma patients. As you can imagine, all trials are building upon this. So getting back to what I tell my patients is they're fine, right? If they're not fine, then they have symptomatic myeloma and need treatment. And no one's going to argue with treating symptomatic myeloma. Correct. We've made great strides with that disease. I say, well, you can continue to be fine. And even if you look at the high-risk criteria, there are many patients at 2 years who still have not progressed. Now, a lot of them have, but there is a substantial 20-30% who have not. There, you've gone 2 years without needing therapy, 2 more years not spending money on expensive therapy. Revlimid is not cheap. And then furthermore, 2 more years where new therapies, potentially better, safer, more effective therapies have been developed. I'm going to watch you very closely. What I do with the high-risk smoldering is I start monthly with labs, which is probably overkill, just to show that there's no really tempo and change in the kappa, the lambdas. Yeah. I think what we know, dynamics is very important, and they're working on this, the myeloma community, looking at dynamic changes. But if you start seeing that kappa go to 100, 200, 500, then fine, I'm going to treat. And I'm not going to treat with Revlimid. I'm going to treat how I treat a newly diagnosed multiple myeloma in the United States, and that's with RVD plus or minus stem cell transplant if they're eligible. If it's stable, then I just follow their labs every 3 to 6 months, and patients are, some are anxious, but in my clinic, they've grown, they get used to it. And I promise you it's better than being on Revlimid. And that's how I counsel my patients. I've yet to have one patient, I don't hide it from them. I'm very honest. I say it's in our guidelines. The Mayo Group recommends it. People who've seen way more myeloma than myself, I explain to them my interpretation like I just explained to you, and they've all been in agreement.
There's so many pearls there. I just think one pearl that people don't often talk enough about is the one you highlighted, which is you follow people quickly to get a sense of the tempo. And I think that's the single most underutilized treatment intervention a doctor has, which is to bring someone back pretty quickly and get a sense of where this disease is, how it's changing, what its tempo is. Every time I'm in clinic with a trainee, I think the temptation is often they want to make the final decision that day. The first day you see somebody, we're going to treat, not treat, or we're going to treat, observe. But the truth is, you can always bring them back 2 weeks, 4 weeks, 6 weeks, 8 weeks, 10 weeks, and bring them back a couple of times in that period and then get a sense of, what does the person really want? What are their desires? What's the tempo of the disease? And I think that's the single most underutilized thing that you only learn when you're finally an attending, because you have that kind of length of your clinic that you don't have when you're a trainee, where it's all, staccato visits here and there with different doctors. So I think that's just a pearl. And I agree with everything you said, which is, if you need treatment, you need treatment. So you need RVD. Which is the standard of care because it has a survival benefit in a cooperative group study against RD. That's a study that was done in, mostly your U.S. sites with pretty good post-protocol thick care. So that's a pretty solid study. So this is good. So I think we both see the irony here, which is that you're giving a toxic chemotherapy drug, Revlimid, which has some risk of second malignancy, which is still going to be kind of question mark, what exactly that numerical risk is in these smoldering patients, because they've all been crossed over at this point, so we'll never get a really good sense of that. And you're doing that for somebody who really does not have myeloma and doesn't really feel the sequela of myeloma. It's a tough pill to swallow. Our time is limited. Let me go to the next topic. Stem cell transplant CR1. We talked about this the other day, and I actually agree with you. I mean, we have the new study that came out of the French group, and this is the randomized control trial of routine transplant in CR1 versus delaying it to a future time when you need it. And at 8-year follow-up, there is no difference in PFS2, no difference in overall survival. PFS1, of course, is better with transplant. You give more drugs early, you're going to get a better PFS. But no difference in overall survival. And with 8-year follow-up now, the control arm, a high proportion of them did get transplant in a subsequent relapse, which is, is what it is. But I guess the question is, for the patient in your office who you're starting on RVD induction therapy, how do you counsel them about, do they have to get a transplant in CR1? Is it okay to wait? How do you think about this question?
Yeah, so the IFM 2009 study, this was a great study done in multiple myeloma. It's continuing to answer important questions. And I think this, in my opinion, does definitively answer the role of transplant in CR1. Is it mandatory or not? So I'm a transplanter, and transplanters like performing stem cell transplants. That's what we do.
So put food on the table. Puts food on the table.
And melphalan autologous transplant, that's the majority of what we do. Myeloma is fairly common compared to some of our other hematologic malignancies. What this study does is it uses standard induction that we're using currently, RVD, and, they ran, half got the transplant up front, the other half delayed, and as you stated, the PFS was longer with the high-dose chemotherapy. They got a big dose of chemotherapy, more drugs. But it's reassuring with, what you said, 8-year follow-up, that the patients who were delayed their transplant, granted, many got it, but that's fine. Some will get it at relapse, that the overall survival was no different. That's like a reassuring feeling for those of us who have been recommending that it's okay to delay transplant. So what I tell my newly diagnosed patients is that transplant, I personally believe, is important and cost-effective in the care of patients with multiple myeloma. Those who see transplant, as long as they see it at some point during their treatment course, they will get the survival benefit. But it really doesn't matter if you get it up front or you get it later. Your total length of life will be the same. I do, though, first PFS, some say it's the most important, some say it matters. I don't think auto plus RVD is curing a substantial population of our patients, but it does offer, in general, a longer first PFS, and it does give the patients, if they value a long PFS on 4 to 5 years as the median, and relatively treatment-free, although they do get Revlimid maintenance.
Of course, yeah.
But there was a survival advantage with that also.
Yes.
So
that's clear.
If they value a relatively treatment, relatively free, then I still don't think it's unreasonable to proceed with stem cell transplant in first CR or in first remission. But it's definitely not unreasonable to delay, especially now with COVID at its worst. I do have a lot of patients delaying. I do collect all those stem cells up. That's something you got to do, though, up front. The stem cells will go bad if they get pummeled with Revlimid, and you won't be able to mobilize them.
Yes.
So I still collect all patients usually after 4 to 5 cycles.
Yes.
And then we either go or not based off that discussion.
I think that's a very fair takeaway from this clinical study. I guess different people tell different stories about what that first PFS means. I've heard people say that first PFS is very long. We're going to have new drugs available for second-line therapy. That'll be wonderful for you. You might want to do it. The alternative is that if you don't do transplant up front, in the time before you relapse and require transplant in CR2, there could be some new innovation that comes in that spares you from transplant at all. So, you can tell whatever story you want about the future, but I think the way you summarize it is nice. And I think that, it's really sobering that, the real thing that you wanted to see in this study was a big survival benefit from transplant in CR1. I think that's what people expected, particularly when you look back at the older studies. Now, that's one thing that has to be said. These older studies that people cite where it has survival advantage, those are done in an era where we just didn't have any of these drugs. And even this study, people got Velcade, people got Revlimid, people didn't get that much Dara, and people didn't get that much carfilzomib. So one would imagine that these novel drugs, I think, if anything, will erode the potential OS benefit of transplant, not enhance. Let's talk about our favorite topic, selinexor.
Oh yes, our favorite.
Good drug or great drug? Which choice?
I would say awful drug. I've been accused of being overly critical, and I'm maybe getting a little scared. But no, I just think it's a bad drug in its present form.
Yeah, it's the what it has going for it is the novel the novel mechanism of action, which everyone likes to talk about. Mechanism of action. Yeah, you keep highlighting the mechanism of action when the efficacy and toxicity are lousy. That's the way they like to do it. I think it's an unusual drug in the sense that I think 10 years ago it would never have been approved. It would be considered, too low a response rate and way too toxic. I think when doctors give it, they find that its toxicity is quite formidable and quite obtrusive. And there are a lot of people who've progressed through many lines of therapy who get to selinexor and say, enough's enough. I don't like selinexor. I also think that in myeloma we talk about these last lines of therapy like we don't have other options. But we often have a lot of other options. One, you can cycle back to something you've given before and haven't given in a while. You can go back to a Velcade, go back to a Revlimid. You've got POM, you've got Dara, you've got ELO. The other option you always have is, you can give someone a bunch of Mel, and if you have extra cells that you've saved, you can give them salvage transplant. You can give him VTD pace. You can give him sort of a platinum-containing regimen. You can give him one of those type of regimens. I think we think we need a new drug. Sometimes we can go to the oldest drugs we've used. Give him Mel 200, give him Mel 160, and then give him some cells back. I mean, how do you deal with it? Let's say you have a patient, we're talking fifth or sixth line, but they're in good shape. They're young, they're healthy, they're in good shape. And let's say you've got some cells in the bank. What are you thinking about in these cases?
Yeah, So, let's give Storm, the trial that looked at this, its credit, if you want to give it its credit. Basically, it took a very sick population, most of them refractory to just about everything, and it gave them single agent selinexor, and some people had a marginal remission. And when we say remission in myeloma, we always have to remember that just means that a protein was lowered for a portion of time, okay? There was no comparator. So I think if it's going to be used, the only place right now that it can possibly be used is in that situation where you truly have nothing else to offer. You've informed the patient that this will not going to make you feel better, right?
No.
And we have no data that it's going to make you live longer. It might keep that protein, or at best, a progressive lytic bone lesion at bay for a little bit of time. I think that's what you can honestly tell the patients. But what I do, and I know, cliche, yes, we try to enroll them on a clinical trial, but let's just assume that we don't have a clinical trial. If they're fit, they're definitely not getting selinexor. If they're truly fit, then they can tolerate, these are the drugs that were around like when I was a kid, give them a gram of Cytoxan, give them alkylating agents. And, there will be some upfront toxicity. There'll be some cytopenias, which I think as a hematologist, we're fairly comfortable managing with good infectious prophylaxis, blood transfusion support. And then you can do a few rounds of them, get their disease under control, prevent the catastrophic crisis that's about to happen, which selinexor is not going to do.
No, it's not.
And then transition them back to, are they truly resistant? I like to think of, cancer cells as, the ones go away that are sensitive to the drug, and the ones that stay are the resistant ones, and then you put them on something else. But it's possible that the ones that were once sensitive to Velcade have now come back. So it's perfectly reasonable to retreat with some of the other agents once you've gotten their burden of disease down with, I like to use hypercytoxin. I don't, there's no comparator data, but you can even use bendamustine.
Yeah.
All these agents can work effective. So I have not had to use selinexor. I probably won't.
Yeah, probably won't probably won't either. I think it's a drug from hell. But I think what you're talking about is something that I don't know if all the trainees really appreciate. But, when people say someone is Len resistant or refractory, that's shades of gray. I mean, I want to give some people some examples. Back when we were treating colon cancer maybe 20, 25 years ago, we just had 5-FU. Maybe 30 years ago, 25, 30 years ago. And people would give 5-FU in different ways. We'd give it bolus, we'd give it infusional, we'd give it this way, that way. Occasionally, you will get a response in somebody who's progressed on 5-FU to 5-FU delivered in a slightly different way. Similarly, when we have many cancers where platinum is the mainstay of therapy, like ovarian cancer, even bladder cancer, or even head and neck cancer. If they've gone so long between platinum, you can reintroduce platinum and often you will get some response. Similarly, with lenalidomide and bortezomib, you can give someone len-based regimen, take them off a len-based regimen, give them a proteasome-based regimen, and then what grows out may be a len-sensitive clone. Yeah. So this clonal selection process is a dynamic process, as you described very elegantly, which is that the thing that is growing out in the setting of proteasome inhibition may be something that is susceptible to a drug that previously was that the overall picture was previously resistant to. So in other words, like the len resistant clone grows out. Now you give proteasome inhibition. You kill that clone down, but then the len susceptible clone, but proteasome resistant clone starts to grow out, and you can give it again. And we often find that these patients who are labeled quote unquote resistant or refractory to drugs can have response from those drugs being readministered. Again, it's a field where there's just not a lot of enthusiasm to do really carefully done clinical trials. There's not a lot of money at stake. But it's so funny that in oncology, when you don't have a drug, you find a way around it, right? For that really fit person who's still got energy, you find a solution for that patient using the drugs you have. The moment you get a selinexor, everyone suddenly feels compelled to use selinexor, even though the data is quite lousy. Boston trial is an embarrassment. It's an embarrassment of a study.
Yeah, I mean, we've not had selinexor up until whatever it was a year ago. We managed in our fit patients to come up with solutions. So, I don't think selinexor currently has a place in the treatment of myeloma. And as you said, I don't know how much time we have, but the Boston study is an embarrassment, unethical almost embarrassment of a study where the control arm is nothing close to what we use in the United States. And this study was done at some centers in the United States.
That's right, and I agree with that. Let's talk real quick about double-hit lymphoma, dose-adjusted R-EPOCH. Dose-adjusted R-EPOCH is an interesting thing. It's like the KRD of lymphoma, because everyone came and talked a big KRD game. KRD is better. Then a randomized trial comes along and KRD is not better. Then they say, well, it's still better in high-risk myeloma. And it's like, okay, well, where's your randomized trial that shows it's better in high-risk myeloma? We can't do it. There's too few people. Sorry, we're just going to give KRD. So that's the line there. Now let's go EPOCH. EPOCH comes along, dose-adjusted R-EPOCH, everyone says it's going to be better than R-CHOP, going to be better. Look at the uncontrolled single-center data from NCI, blah, blah, blah. They do a randomized trial, the CLGB study, dose-adjusted R-EPOCH, not better than R-CHOP. Now people say, but, you don't have power to look at double hit. You don't have power to look at PMBL. It's still better for those conditions. And so you say, well, what's the study that shows it's better for those conditions? Oh, sorry, there's no randomized study there. It's really interesting. It's this phenomenon where you can use a more aggressive, more toxic regimen in a subgroup of a disease, even when that more aggressive, more toxic regimen fails in the overall cohort, by claiming you didn't have power to exclude a benefit in your more toxic regimen. It's sort of like an inversion of the burden of proof. The burden of proof is on the critic of EPOCH and the critic of KRD to show it does not work better in a high-risk setting than it is on the person who wants to use it. How do you think about dose-adjusted R-EPOCH? Who do you use it in? What are your thoughts?
Yeah, so as you alluded to, the CalGB 50303.
That's good. That's hardcore. I remember those numbers.
And I have no trial. I believe that's it. They randomized, advanced stage DLBCL to R-CHOP versus EPOCH, dose-adjusted EPOCH. And just so you know, me finishing fellowship, dose-adjusted EPOCH was, we would just find any reason in the book to give that extra topicide and that magical infusional therapy. You get those neutrophils lower, some mucositis while you're at it in neuropathy. We would look for any reason in the book. First we just said double hit, and double hit specifically refers to a MYC translocation in the presence of a BCL2 translocation and or BCL6. Although the more we look at it, the translocation partner matters. It seems to really be dependent to be when they translocations with the immunoglobulin heavy locus. But that in retrospective data there is maybe some benefits in pretty lousy retrospective data, but it's the best we have, and I acknowledge that. So we accepted using it in that traditionally poor prognosis population. But then we started saying, well, let's give it to these double expressors.
Double expressors, and expression is in the eye of the beholder. Yeah.
They're not double hits. They don't have the translocation. They just express the proteins on their surface, BCL2 and MYC. Well, what's the expression cutoff? Maybe 40, 50%, depends on the group looking at it, depends on the pathologist and how they're measuring it. But then we would say those people do worse. Let's give them EPOC. Oh, they have a little bit of extranodal disease. Let's give them EPOC. It's in the breast. That's a bad prognosis. Let's give them EPOC. So just about everyone was getting EPOC before we had a randomized data showing that we were benefiting these patients. Yeah. And as I always tell my trainees and my patients, we do not need a randomized study to tell us that intensifying therapy will not. We know it's going to increase toxicity.
Yes, exactly right. Yes.
You don't need a study to show that giving more chemo, more topicides, there's going to be more toxicity issues. But we do need a study to show that it's helping patients. So they did the randomized study, and lo and behold, it showed no overall survival advantage, it showed no response advantage, and it showed no progression-free survival advantage in a well-done study. If you read the conclusion of the study, I disagree with the conclusion, even though I love the study. They still say, in very specific populations, we don't want to discourage the use of EPOC because it can be a game, you can't say that. The problem is, and as I've told my trainees, if I presented a double hit lymphoma at tumor board, I love my colleagues, but if I presented at the lymphoma tumor board and said I'm giving R-CHOP, people would be critical of me.
Oh,
but if you truly look at the data, we know that dose-adjusted EPOC causes more neuropathy, mucositis, and infections, for sure, and we have no data that it benefits them. So I actually still don't think it's unreasonable to give R-CHOP. And think about it. These double hits lymphomas are really bad. Do you really think the fix for these double hit lymphomas is magically some more chemo? I think hopefully with some of the novel or better drugs that we're developing, bispecifics, immunotherapeutics, that we can finally beat R-CHOP. But in my opinion, R-CHOP is still the standard of care for most patients with diffuse large B-cell lymphoma.
Yeah, that's exactly the conclusion I come to, which is that there's a lot of peer pressure to give it in double hit, but there's not a lot of good data. And I guess people forget, I think, the history, which is like in the 80s, late 80s and early 1990s, EPOC was pro-Cytobomb. EPOC was, we had different multi-drug combination regimens that people thought were better. And if you compare, 190 people treated at the NCI versus the, R-CHOP pooled average, it looks better. And unfortunately, when you test it head-to-head, it is not better. But back when they did those studies, they didn't parse out these tumors into all these little categories. So they couldn't say, well, pro-Cytobomb is still better for double-hit lymphoma. If they could, I bet they would, and then they would have said that. I think it's almost unfalsifiable because, like right now, what's the data we have? We have retrospective data that shows if somebody has a true double-hit lymphoma and they get an R-CHOP-containing regimen, we'll agree the outcomes are poor. The curative fraction is maybe 5% at best or even lower than that. I mean, maybe there's no cure from giving those chemotherapy drugs, period. But it's low. If you give them EPOC, those patients are just selected patients. They're treated in, tertiary referral centers. They're fit enough to tolerate EPOC. They pass the EPOC eyeball test. They're not in any way comparable to the historical population of R-CHOP. You can't solve it with propensity score. And I haven't even seen anyone try, but I don't think they can, because the people who do these analyses are not actually, for the most part, very formal epidemiologists. They tend to be people who are clinicians who have different training in those spaces. But I don't think I've seen anything that's like propensity score matched or inverse probability weighted or anything sort of the modern techniques to try to get comparability. But I think they'll be flawed. I think that fundamentally you're comparing different groups of people. The people who you historically were treated with R-CHOP, and the people who you think are fit enough to take EPOC. So I just don't put any credit, it's not even data to me. It's like, I don't know what it is. It's just something you tell yourself to make yourself feel better. It's a story. Let me ask you this question. No, go on. Finish.
I just said people with an inherently bad prognosis in any cancer, it's in our almost blood or training. We want to make sense, give more. you do feel better. You tell the patient, this is bad. I'm going to treat you with more stuff. And it does feel better, although when you really think about it, this took me a few years in my training as an attending really to realize this, that, all I know is I'm causing toxicity. I don't know I'm helping. So at least for me, we have a randomized study now. They did it. So I think the question is close. We have our answers.
Yeah. I want to end with the sort of philosophical question, but I guess I think it's interesting to me, which is that, I think when somebody looks at oncology from the outside, they often have two very strong positions. One position is, I think, a position that most Americans may have, which is like you all are given poisons and it's a very tough field. And people always ask me, like, how do you even do it? Like every day, every one of your patients is dying, and how do you even do that? And I want to say, like, whoa, easy. It's not so dire. I mean, we're curing people, take care of Hodgkin's, non-Hodgkin's, we're hitting the ball out of the park with those cancers, particularly Hodgkin's, early breast cancer. We're curing a lot of people. In fact, maybe we're overdiagnosing some, but that's okay. That's good outcomes either way. Testicle, we're hitting the ball out of the park. We really have some substantive improvements. Rituximab was amazing. HER2-directed therapy is really solid, at least the first drugs. Imatinib's amazing. I would even say, like, if somebody's really symptomatic with myelofibrosis, give them ruxolitinib. That's really good. As much as I'm critical of ruxolitinib's overuse, like in your GVHD. No, just kidding. We'll talk about that some other time.
People feel better for myelofibrosis.
Yeah,
people feel better.
Tons better. Better. And now with immunotherapy, we have some cure, melanoma, we're curing some people. I mean, I'm willing to say that now that we have enough data. Lung cancer, I don't know if we're curing people, but we're certainly improving survival with immunotherapy. Okay, so I guess what I want to say is that, like, the more you practice, you realize that, like, there are a lot of things that are very efficacious. At the same time, there has long and then the other pole is that everything you're doing is wonderful, and that's really kind of a mantra that I don't think the lay public has. I think, like, the average KOL has that, and you go on Twitter and it makes it seem like everyone's getting cured every day, and that's obviously incorrect. And I think both extreme is harmful. When I started in my career, I think I came in sort of in the middle. And over time, I've learned I've learned very quickly the things that we do that are great. And so I quickly was buying into that. It took me a while to see all the ways in which we screw up. And they tend to be these things that we've talked about here, which is somebody was feeling fine and you thought you knew, they're feeling fine and they don't have a complaint, but you thought it would be better if you did something and you inserted toxicity there. And you never really had proof that you're making them better off. And in situations like that in oncology, we often blunder. Like, we've had many examples, like the CA-125 story in ovarian cancer, many examples where we thought we'd make somebody who felt good better off, and we fucked it up. Because it's easy to take somebody who feels good, and the only way you can go is make them feel worse. And whether they have a countervailing benefit is a tough thing. It's not easy. It's biology. So that's a way we err. The other way we err is you take somebody who is not going to do well. They have, treatment-related AML. They have poor-risk cytogenetics. They have double-hit lymphoma. They have, like, plasmablastic, or they have something aggressive and bad. And our default answer in oncology is, like, just give them more drugs, more treatment, everything. And sometimes at the end of all that, you've just, like, tortured somebody and you've not really improved the outcome. And so I guess it took me a while in oncology to come to that conclusion that there were these two classic cognitive errors, that if it's good when you have the full-blown disease, it's got to be better when you give it earlier. And that's a cognitive error because that's not always the case. And that if they have a bad outcome, even when you give the good therapy, you've got to crank it up a notch. That's another cognitive fallacy because that's not always true. Sometimes it's true, sometimes it's not true, but you need data either way. I guess my question for you is, when were you in your career that you started to see these two problems? Because I think you're a very articulate spokesperson on Twitter that these are two problems. So where were you in your evolution that you started to recognize that?
It wasn't until these patients were really truly under my responsibilities in attending, and I'm getting called on everything, managing their toxicities, doing a lot of inpatient attending, seeing a lot of the bad things that we unfortunately see in oncology. And it also, not to make you feel better, was listening to some of your work. No, I'm being serious. Yeah. I mean, following you on Twitter, listening to some of your podcasts, reading your book, realizing, and I was in that other group, and realizing that, starting to question a lot of the things that I was doing in oncology, just because, experts or colleagues were telling me one thing to, who am I to say as some junior attending that maybe they're doing it wrong. It feels weird. Maybe my thought, the first things that went through my head were, maybe I'm wrong. If they're all telling me one thing, maybe I'm the one that's wrong. And it took a lot of, critically learning trials skills that I didn't have when I graduated. seeing toxicity in patients to come to the conclusion that a lot of what I was doing was not proven to help. And I do think that especially with the expense and toxicity of what we do in oncology, we need to know we're helping patients. And I think that's just, people are always going to disagree on this. But my conclusion, especially with therapies like maintenance therapies or treating asymptomatic patients, if you're going to make someone feel worse, who by definition is either in remission or doesn't have actual cancer, we need to know for sure we're helping them. And I want to be proven wrong.
Yes.
Show me that, Revlimid up front helps these patients. And, I still don't think I did anything wrong by not treating them, and I'll gladly start giving it. But I just feel uncomfortable, as you said, taking healthy or asymptomatic patients or patients that are in remission, giving toxicity and expense without knowing true benefit. And once I realize that, it's really easy for me to make those decisions now.
Yeah, and I think once you start to realize that, you become like a much better doctor. And there always been doctors who, I've met so many senior oncologists, men and women, all stripes, all different places, from Kaiser Permanente to VA to like community settings to private practices. And a lot of people independently kind of gravitate to this philosophy over years. We all find it different times. I think for most of us, as you say, like it only clicks for us when we're attending, when you have that ultimate responsibility, when you have the responsibility of recommending a treatment and you see a side effect, and then you really have to agonize and say, did I make the right call with the information I had at the time? And I think you put that well, which is that like if a future world comes across and they show that giving DARA KRD for MGUS improves overall survival, sure, we're going to do it. But the burden of proof has to be on them to show that it does that. You can't just give DARA KRD and say time to MGUS is delayed, or no, time to Smouldering was delayed, which is what I think the companies want you to do because they're going to rack up a lot of charges. And that's the other bias, that all of the biases we're talking about, kind of the classic over-treatment biases, are countered by the industry's presence because they make more money. The more you treat, the sooner you treat, the more you continue, all those things. So anyway, I think it's important to come to this philosophy. And I guess the last thought I had was like, I don't know. It interests me, and recently I got pulled into this a little bit because I wanted to advise like a junior person, like, time is a limited resource, and it's like you can only focus on what you should think about in your career. Like one is, we're doctors. You gotta you gotta think about like, what did I say? Like cost, toxicity, invasiveness. You want to focus your energies on things that cost a lot, very toxic, that are invasive, that if you're wrong, you're subjecting the healthcare system to costs that insurers are paying, that are being unquestioned, that only you can question because only you have HemeOnc training. And so I put this in the context of like, all the articles I read about, I don't know, somebody writes some article, they, even oncologists do this. They say that like, patients who present with myeloma, who decline all myeloma therapies and pursue vitamin C and incense candles, they don't do as well as people who take all the myeloma therapies and they have some curve and they get some paper out of it or some poster. And I want to say, of course they don't do as well, because you're giving them a bunch of bullshit instead of giving them all the drugs that actually work. So surprise, surprise, they don't do so well. And I was like, and you're not some, Sherlock Holmes for figuring out that they don't do well when you give them a bunch of things that don't do anything in myeloma, don't even kill one plasma cell. It's very, very simple to point that out. And so my point is that, like, if you know things about myeloma, if you know things about surgical oncology, you got to apply your critical thinking to your field, because you're the only one who can do it, and we really need you to do it. And the more, like, for every 10 doctors you get to think the way Aaron Goodman thinks, I think you help a lot of actual people avoid crazy stuff that the momentum of the field is trying to push them into. So I guess my last question, to make it a question, like if you were to advise a HemeOnc trainee, let's say you got a HemeOnc trainee and they want to do heme malignancies, which is pretty cool. One of my biases, I really like heme malignancies. I think it's fascinating. They want to do heme malignancies. They want to go have a research career. Like, what would you advise them to, like, I don't know, how should they approach their questions, their publications? Like we have this Mani who's working with us, who's awesome. Like, how can we have more Manis? Like, what would you tell these kids?
Well, it's a double-edged sword, because so like for someone like me, what interests me is actually I love patient care. Yeah. I love learning from all the patients I take care of, and I love teaching. But what's important if these people want to be academic bone marrow transplanters or leukemia doctors, clinical trials and that type of research is important. And I've just become honest with myself. When I started, I did company sponsor. I still do a few of them. doesn't, there are people that do it and they're super important, but that's not, I don't get as much enjoyment doing that as I do, honestly, teaching the medical students or having the fellow in my clinic. And when I honestly realized that, I just started changing my focus. The problem is when you tell a trainee that they'll always point out, well, Dr. Goodman, if I don't have any publications at UCSD, who's going to hire me? So I think I don't have a great answer, but you have to maybe start off doing a little both. You do need to get some work, some experience with clinical trials, experience that, but then really just what you like. I like teaching. I like taking care of patients. I do more clinical work, and I do way more. Anytime I get a teaching opportunity, I honestly, the residents now know this. They ask me all the time for a report, and the fellows, I just say yes, and I make time out of that. And if you make yourself unique in that way, the university, they are starting to recognize. They're like, hey, this Dr. Goodman's a really good teacher. He's getting good reviews, and they're starting to offer me more opportunities with that count just almost as much as research. So I think that's the best advice I can give. Truly do what it's cliche hearing myself say this, but do what makes you happy.
Yeah, no, that's well
don't
put.
Just be a clinical trialist because that's what you think will make you happy or get you all the publications. It definitely will get you publications. Let's be honest. I do clinical industry-sponsored trials. I'm part of one. They send you an email and they go, are you interested in doing this? And I go, okay, this sounds like a good treatment for my patient. You help enroll patients, and then they write the thing, they do the data analysis, and then your name gets on the thing. I'm part of that. But I don't really feel great about that other than the fact that maybe I got my patients access to a good therapeutic that I feel good about, but the rest I don't. As you said, we're working with an awesome fellow, Manny. Take a disease you're interested in. You're going to find flaws in how it's treated. You're going to see it in your clinical practice. And then you ask yourself, how can I maybe measure this and show that this is actually a true problem and not just something I'm seeing? And then once you show that, then ask yourself, well, how maybe can we fix this? And then you can go from there, and you can come up with many ideas.
That you nailed it in like two things. I think that you nailed it. One, you got to ask yourself what you want to do. And for you, the passion is teaching. And to be honest, that's like one of the things that I actually enjoy the most. Whether or not people enjoy learning from me is another story, but I enjoy telling them what I think about things. And to be honest, I view this as an extension of my enjoyment of teaching, making a podcast that probably mostly trainees listen to. I believe from some feedback I have, and practicing doctors, and doing, those kinds of things. And then the other point I think you make that's really good is that, when you have a field you like, your intuition, you're like, oh, well, why do we, every time you get that first question, why do we transplant every T-cell lymphoma patient with, such and such? Why do we do this maintenance in these? And then you go on up to date and you're like, and it's like, studies show that doing this delays the time until the next treatment. And you're like, okay, but do they live longer? And you're like, there's no benefit shown in this study. However, it was unable to look at that, blah, blah, blah. And then you start to ask yourself, and then I think you just have to run with those questions. And I think the temptation is to think, oh, I'm junior, I don't know enough. I must not know why. It must be right. I must be wrong. So I don't want to show other people that I'm wrong and don't know the answer. So I'm just going to, play along. But I think the answer is honestly, when you look hard enough, you're like, oh, there's actually a real tension here, a real debate that people aren't really openly discussing. We've fallen into one thing mostly by historical accident. And I think about our paper, you talk about if trainees want to write something, I think they should check out what we wrote, Persistent Challenges with Treating Multiple Myeloma Early. It's in Blood, which is good. I was actually, and you and I were both kind of surprised that very surprised Blood took it. We're surprised Blood took it. And this is a paper very simple. It's called Persistent Challenges in Early Myeloma. So all of the things we talked about in the beginning of the conversation, we flesh out, we add some more stuff, and we say that these are open questions in this space. And I think it connected with at least the people at Blood who thought about it and reviewed it and edited it. And I think it'll connect with other people. And I guess I'd recommend that you find your own, I don't know, your own thing that is a pebble in your shoe, from radiofrequency ablation for localized hepatocellular carcinoma to why are we using pertuzumab in low risk HER2 positive early stage breast cancer where the benefit is minuscule and the cost is massive. You find that and then you probe it and you write about it. And I think I find the Blood paper we wrote, I'm way more satisfied with than most things I did this month. Last thoughts for you, Aaron Goodman.
No, I said, right. You reached out to me and you could see that I was troubled with a lot of what we were doing in the treatment of of smoldering myeloma, and then this myeloma that is asymptomatic, but we call myeloma based off the light chain. And I hadn't done a deep dive. I did it. I looked at all the stuff, and I was like, man, this data's not so great for this. And we just put in a little editorial. I learned in the process, and
me too.
Yeah, I think it will hopefully reach out to people. I had some people already email me, and it's not a research publication, but it's a publication. It shows that we've critically thought about this, and it's opening up new avenues. And we're meeting, as you said, we're working with an awesome fellow, KU, who reached out to us, who shares similar, and we're expanding. And now I think we have a lot of good stuff in store that just really happened over the last 3 to 6 months.
Yeah, and it's been a lot of
fun. We had in Twitter, which is amazing.
Exactly. It's mostly, and that's the other thing. It's mostly because we saw each other saying things that we all have been feeling on Twitter. I saw you saying some things that I've been feeling and really liked them, and I think Monty did too. And that's how we all came together on this topic that maybe we're the only 3 people interested on Earth, but at least we found each other.
The editor liked it. Someone liked it.
The editor liked it.
Hopefully we'll reach out, and if people disagree, I'm all about debate. Maybe I'm wrong about something. I'm the first. You show me, and we can have a discussion why some of my thinking is wrong, and I'm happily to discuss it.
I love a good debate too. But if you debated on Twitter, this is how it would go. First thing they'd say is, Aaron Goodman, you don't see patients. You're like, well, actually I do. You don't see myeloma patients. Well, actually I do. And you're like, oh, but you don't work at an academic center. I do. And you're like, oh, that's the classic Twitter debate. The credentialism 101. Okay, Aaron, this has been a pleasure to talk to you. I'm glad we were able to do this. I will give you the last word.
No, so thank you for having me. And again, just to try to reiterate some of those things, I think if you had to summarize, my beliefs over the last few years, we shouldn't be treating smoldering myeloma. We should not be using selinexor yet until we have more data. And yes, go after some of your passions. If it's teaching, go after that, and you'll see where things take you.
That's well put. And I wanted to talk about belantamab, but I couldn't read my notes here about it, so I couldn't talk about it. Well, next time.
Another discussion.
Another discussion. Thank you, Dr. Goodman. You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.